The next case that we are going to present is also a rare entity, though the presentation was a very common clinical presentation that we see in day-to-day clinical practice. And Dr. Joyner and Dr. Rajshekhar are going to present case from our side. Dr. Rajshekhar.
Greetings and warm welcome everyone for this presentation on an uncommon cause of a common surgical condition by Unit 3 of Department of Surgical Disciplines. Patient under consideration is a 31-year-old lady who is a teacher by occupation and resident of Delhi. She had a recent acute abdominal event that happened a week ago, for which she was admitted in an outside hospital and was conservatively managed, and she had improved after the conservative management. However, as a part of evaluation, a CT was done and surgery was advised for the patient, for which the patient sought a second opinion and she had come to her OPD. The patient was asymptomatic when she presented to us, but on history, the patient had pain abdomen for 1 week, which was acute in onset, severe in intensity, and colic in nature, localized to the central abdomen. The pain was associated with vomiting of 2 to 3 episodes per day, which was non-projectile and non-bilious in nature, containing food particles. The pain was associated with non-passage of feces and flatus for 3 days. There was no history of abdominal distension, hematemesis, or melena. There is no history of constitutional symptoms or jaundice. The patient was admitted and managed conservatively with near-peroral nasogastric decompression, intravenous fluids, and antibiotics for 3 days, after which she has improved and started to tolerate initially liquid diet followed by semi-solid diet. On further history, the patient had a single episode of colicky abdominal pain 6 months ago, which lasted for a few hours and relieved on oral medication. However, it did not require any hospitalization and no further evaluation for the pain was done, as it was mild in intensity and short-lasting. There were no known comorbidities and no history of any prior surgeries. She is a non-smoker, non-alcoholic, and is unmarried with regular menstrual cycles. On examination, the patient was comfortable at rest and the general physical examination was unremarkable. Her pulse was 82 beats per minute and her blood pressure was 108 by 70 millimeters of mercury. On perabdominal examination, the abdomen was non-distended. There was mild tenderness in the periumbilical region, but with no guarding, no rigidity, and no rebound tenderness, and no organomegaly. The digital rectal examination and the other systemic examination were normal. So with the history and physical examination, a provisional diagnosis of partial bowel obstruction, the imaging which the patient had with her was reviewed. The patient was advised admission for further evaluation and management on the basis of imaging. Now I invite Dr. Palak from Department of Radiodiagnosis for her expert comment on the imaging. Thank you.
Good afternoon. We'll be seeing the contrast enhanced CT of the patient done outside in January 2021. So the coronal reformats. In this, we can see there is the invagination of the small bowel loop within a dilated midline small bowel loop along with the mesentery, just giving the classic bowel within bowel appearance, suggestive of intussusception. The internal herniated bowel represents the intussusceptum. However, the outer bowel is the intussuscipium. And there is associated mild mesenteric fat stranding and fluid within the abdomen, and upstream dilatation of the small bowel loops, which are fluid filled. And the IC junction appears normal in this case, and the wall of the bowel is congested with thickening. However, there is no evidence of any thinning or abnormal enhancement of the wall, or any pneumatosis or pneumoperitoneum. And in this case, we can see this fat attenuation lesion, which could likely be the lead point for this case, lipoma. So, concluding, this is a case of intestinal obstruction secondary to jejunal-ileal intussusception with lipoma acting as the lead point in this case, and there is no obvious signs of bowel wall ischemia in this. So the patient presented to us, and an abdominal X-ray and a chest X-ray was done in our department. The chest X-ray, no evidence of no abnormal findings were seen on the chest X-ray, and there were no free air under the diaphragm. In the abdominal X-ray, however, we can see some air fluid levels in the pelvis, no dilated air-filled bowel loop seen, and the large bowel loop was ended with air. And an ultrasound abdomen and pelvis was done in our department. The images are not available for the same. However, it confirmed persistent jejunal-ileal long segment intussusception involving the mesentery. However, no lead point was seen and there was mild fluid in the pelvis.
So although the patient was asymptomatic and was vitally stable, with the imaging findings suggesting an unresolved interception with possible vascular compromise. So a preoperative diagnosis of small bowel obstruction due to interception was made and the patient was advised surgery. The plan was to do a diagnostic laparoscopy and proceed based on the intra-op findings. Her preoperative blood investigations were normal, and after necessary informed written consent and arranging adequate blood and blood products, the patient was taken up for surgery. So as you can see here, an initial 12 mm camera port followed by two 5 mm working ports were inserted for diagnostic laparoscopy, and a subsequent small Fannerstein incision was made. During the surgery, a bowel work was done initially, during which we found an intercepted segment of small bowel, which is approximately 100 centimeters proximal to the IC junction, as you can see in the figure A. And on attempted reduction of the interception laparoscopically, we could find a patchy area of gangrene, as you can see as highlighted in the figure B. So a decision was made to deliver the bowel out through the Fannerstein incision. And as you can see in image C, that is the delivered bowel showing the unhealthy area with a focal area of gangrene. So a 45 centimeters of ileum, which included the intercepted, gangrenous and perforated segments, was resected, and a side-to-side anastomosis was performed. After securing complete hemostasis, the abdomen was closed in layers over a pelvic drain. These are the specimen photographs showing the ileum, resected ileum with unhealthy part and a focal perforation. So, and the postoperative course of the patient was uneventful, and she was discharged in a vitally stable condition on post-op day 4 after tolerating liquid and semi-solid diet. Now I invite upon Dr. Rahul from Department of Pathology for her expert opinion on the pathology.
So the specimen which we received on gross examination showed these multiple serosal nodules like this. Here was a nodule. So on enlarging them, these are the vague nodules we can see. So examination of sections from these nodules revealed a spindle cell tumor which was arising on the serosal aspect like this. You'll see all of them in high power soon. So this lesion was arising from the serosal aspect and going into the muscularis. This is the muscular layers of the muscularis propria here. Tumor is seen to be infiltrating these muscular layers of muscularis propria. Then it is going deep. So here is the muscularis layer, and the tumor is this these waves of hyperchromatic nuclei which you can see. It's still further infiltrating into the muscularis and reaching up to the serosa and causing an ulceration on the reaching up to the mucosa and causing an ulceration there. And this area of ulceration is seen as the ulcerations in the gross specimen. So this is the normal mucosa here, and here you can see the ulceration. So this is the full thickness section of the bowel. So the tumor is found to be transmurally infiltrating. That is, from the serosa to the mucosa, the tumor is completely infiltrating the bowel wall. On high power, the tumor is found to be composed of these spindle cells, which are very pleomorphic, arranged in a haphazard pattern with frequent mitotic figures also. So here we can see the mitotic figures here. The mitotic figure. There were many mitotic figures which we could identify in the tumor. So our differential diagnosis on this morphology and involvement was a gastrointestinal stromal tumor or a desmoplastic variant of malignant mesothelioma or a dedifferentiated liposarcoma. Sought the help of immunohistochemical markers, and we had done CD117 and DOG1 for a gastrointestinal stromal tumor, both of which were negative. Desmin was non-contributory. CD34 was also negative, which ruled out vascular neoplasms, and calretinin for malignant mesothelioma was also came out to be negative. HMP45 being negative also ruled out clear cell sarcoma, which can also present as a spindle cell neoplasm with areas of clearing, as we can see, as we saw previously. And S100 showed diffuse nuclear and cytoplasmic positivity in the tumor cells. SMA showed focal positivity, whereas MDM2 showed diffuse strong nuclear positivity. All these immunohistochemical markers point towards a liposarcoma. Along with this, the high proliferative activity of the tumor was highlighted by Ki67 labeling index, which is seen here. which came out to be around 40% in the tumor cells. So based on all these findings, low-grade dedifferentiated liposarcoma diagnosed. There was also multiple mesenteric deposits of the similar tumor, which we could identify. However, there were no lymph nodes seen after even though the fat, the mesenteric fat was dissected extensively.
We were surprised with the histopathology report suggesting a malignancy, and though the margins were negative, there were mesenteric deposits. So the patient was called back for review, and on medical oncology opinion was sought, and a contrast-enhanced CT of abdomen and pelvis was done as advised by the medical oncologist. Now I invite Dr. Palak for review of the radiology.
Patient underwent a follow-up contrast-enhanced CT in our department. In this section, axial section, we can see there's a fat attenuation lesion with mild thin interceptations in the ilium. However, there is no obstruction or overlying intussusception at the site of the lesion. The consequent sections, the bowel loops are not dilated, and there is no fluid or any other mesenteric fat proliferation or mesenteric lesions. Concluding, in the follow-up CT, there is an ileal lipoma with no complications secondary to it.
With the concern that it was reported as a malignancy as the cause of the intersusception and an additional lesion on fresh imaging, and histopathology also suggesting mesenteric deposits, a decision was made to go ahead with diagnostic laparoscopy and resection of the new lesion. The problem of localization of lesion intraop was thought about because the bowel work which was done during the first surgery was normal, apart from the area of intersusception. So an enteroscopy was kept as a standby. And to our surprise, in the second surgery, in the diagnostic laparoscopy, we found another area of intersusception, 20 centimeter proximal to the anastomotic site and 120 centimeter proximal to the ileocecal junction. This was despite the patient being asymptomatic and the radiology showing no intersusception. So laparoscopic reduction of the intersusception was done, and it showed a tumor at the lead point, as you can see now. So a 30 centimeters of ileum was resected, which included the tumor, the previous anastomotic site, and the mesentery, and a hands-on side-to-side ilioileal anastomosis was done. And the postoperative course of the patient was uneventful. She was discharged on day 4 after tolerating liquid and semi-solid diet. Now I call upon Dr. Rahul for the review of histopathology.
So the second lesion which we received was entirely different from that of the first lesion. So here we saw this multiple lobules which was infiltrating the muscularis propria here. All these lobules were composed of mature adipocytes on high power. So, and these mature adipocytes were separated by thin fibrous septa. So this was a very benign looking lesion. So composed of sheets of adipocytes which are separated by thin fibrous septa again. Yes. So this we can compare the present lesion on the left side with the previous lesion on the right side. There are no pleomorphic benign pleomorphic malignant looking spindle cells as seen on the right side in the left side lesion. So this was and also we sought the help of IHCs this time also. So MDM2 came out to be negative in this new lesion. There were also some lymph nodes which were all of them turned out to be reactive. So there were also serosal nodules which also on examining the sections gave the same appearance. So this was a lipoma, and this diagnosis was the diagnosis of intestinal lipomatosis with liposarcoma was made on this.
So after reviewing all the histopathologies, the final diagnosis of intestinal lipomatosis with dedifferentiated liposarcoma presenting as partial bowel obstruction was made, and the patient is being followed. Patient is asymptomatic at a follow-up of 6 months and is planned for a repeat CT scan after 1 year. Now I invite upon Dr. Joyner Abraham, Senior Resident of Surgery, to carry forward the discussion.
Extending my warm greetings to everyone. We'll pass on to the discussion part of it. So intussusception is one of the rare causes of intestinal obstruction that we do see day to day in surgical practice. As such, intussusception means the telescoping of a segment of a bowel into an adjacent segment. It is usually the proximal segment of the bowel that goes into the distal segment. 95% of the time, intussusception is found in pediatric population. It is common in the age group of 3 months to 3 years, with peaking at around 4 months to 6 months. That is, the baby is planned for weaning. Usually, it can be asymptomatic or transient also, but it can also lead up to obstruction, inflammation, and possible ischemia. So you can see the most common type of intussusception is the ilio-ileal intussusception, which is followed by the ileocolic intussusception and colocolic intussusception. So the part of the bowel that goes into the distal bowel will be called as the intussusceptum, and the part that receives it will be called as the intussuscipiens. So in adults, intussusceptions are even very rare, and they constitute only 1% of the total cause of bowel obstruction. Unlike in pediatric age group where we don't find the lead point usually, in adults it is usually associated with the lead point. Most of the time it is a benign lesion such as a lipoma or a fibroma or a hamartoma, but it can also be malignant. When it is malignant, usually it is a metastatic deposit, lymphoma or cyst when it is for a ilio-ileal intussusception, but it is usually primary adenocarcinoma if it is a ileocolic or a colocolic intussusception. Soft tissue sarcomas as such are very rare in small bowel, and its reports are usually limited to K series and reports. And ileal STS leading to intussusception, in English literature search, there are only 2 cases reported so far. The assets to intestinal lipomatosis. Lipomatosis is the presence of multiple lipomas in the body, and intestinal lipomatosis as such is a very rare disease, and it is characterized by infiltration of mature adipose tissue in the bowel wall. It is 90% of the time localized into the submucosa of the bowel, or 10% of the time it is usually in the subserosal plane. Usually intestinal lipomatosis is asymptomatic, but when it is larger than 2 centimeters, it can lead on to complications and can present as intussusceptions, bleedings, perforations or obstruction. On English literature search, so far we could find 17 documented cases of intestinal lipomatosis, and 4 cases so far has presented as intussusception. These are the 4 previous cases which have presented as intussusception. So all these 4 cases which have presented previously was ileocolic intussusception. 3 cases underwent a limited or a formal right hemicolectomy, and one of the case had to undergo a total colectomy. Or in our case, we did a lap assisted resection of the small bowel. So the chance of lipomatosis getting transformed to a liposarcoma. So far, it has been believed that liposarcoma cannot arise from a benign lipomatosis. That is, liposarcoma usually has a de novo origin. But the recent pathological studies and case report have suggested that the transformation of lipoma to a liposarcoma is still possible, and it is usually occurs in recurrent cases also when the size of the lipoma is more than 6 centimeters. So liposarcoma as such, it is one of the commonest soft tissue sarcomas along with the rhabdomyosarcomas. Usually we name sarcomas on the basis of the cell of origin, and in liposarcoma it is the adipocyte which is the progenitor cells. And according to the WHO classification, so far there are 4, they have classified the liposarcoma into 4 types, that is the well differentiated, dedifferentiated, pleomorphic and round cell or the myxoid liposarcomas. Usually it occurs in the middle age or the elderly, unlike in our case in which she was a very young female. It can occur anywhere in the body, but usually it occurs in the retroperitoneum or extremities, and it is very rare usually in the small bowel. The diagnosis of a liposarcoma is usually made in the post-op histopathology by immunohistochemical examination. It is usually strongly positive for MDM2 and CDK4. In our case also, it was strongly positive for MDM2. And you have to also rule out the GIST or perivascular epithelial tumors with other tumor markers which you have done in our case. And again, primary GA liposarcomas, therefore there are total 38 documented liposarcomas that we are able to find in literature search. They have so far varied presentations like obstruction, intussusception, right iliac fossa mass, GA bleeding and perforation. So these are the 11 cases that we have found so far on literature search. As you can see, all the cases here
have the age group at over 50 and around 84. And in all of these cases, they have done an open surgery. In our case, we have done a lap-assisted bowel resection. And the treatment of choice or the standard of care for treating liposarcoma is complete R0 surgical resection, which we have achieved eventually in our case. And whenever we find an R1 resection in histopathology, we have to always go in for a re-resection. That is, the effectiveness of chemotherapy or radiotherapy is still unclear. There are reports of people giving radiation therapy in recurrent liposarcomas in extremities, but it is, however, not possible in small bowel. Current NCCN guidelines also don't recommend adjuvant therapy after R0 resection. And again, for dedifferentiated liposarcomas, it differs from other liposarcomas as such. It has a very high local recurrence rate of 40 to 60%, and the chance of metastasis is also 15 to 20%. And again, this chance of local recurrence is usually within the first 2 years of the primary surgery. Hence, a very close follow-up examination with imaging every 3 to 6 months is recommended for the initial 2 to 3 years, and within annual follow-up. We are also following our case very closely. So, why this case? So, this case as such gave to our treating team a lot of surprises. Initially, the patient was completely asymptomatic when she presented to us, and it was the imaging which made us go in for and prompted for an emergency surgery. And again, in the surgery, we could find out a perforation, which didn't possibly cause any symptom because it was concealed in the interception. And again, when we went in for the second surgery, patient was again completely clinically stable, and the imaging also we couldn't find the interception. But again, when we went in, we could find an interception. And again, in the histopathology, if the first histopathology liposarcoma was a surprise to us, again the intestinal lipomatosis was also a surprise, because both lipomatosis and liposarcoma are very rare in small bowel. And as such, whether this liposarcoma has been transformed from a lipomatosis to a liposarcoma or whether it is de novo, we might not be able to tell it very surely. The take home message: malignant lesion should always be considered as a possible source of interception even in a young adult, and intestinal lipomatosis with liposarcoma is still a possibility. And when we find a single lesion, we will have to always carefully look for multiple other lesions. This outset, I thank the Department of Radiology and everybody, and Professor Rajendra Bashit sir is coming for his expert opinion. Thank you.
On our geology and medical oncology were with us throughout this, and fine. Dr. Sameer Bakshi is the one who was coordinating with us. Not Dr. Deepam has come. I would like Dr. Raju and Dr.
I think this case truly highlights the famous quote of William Osler: medicine is the science of uncertainty and the art of probability. Because at every stage, there was some discordance between the clinical features and the radiology. When we saw these images, we were persuading the surgeons that you need to go in immediately, and they said the abdomen is completely silent. There are no findings at all. So although the dictum is that we treat patients and we don't treat images, but well, I think imaging has reached a point where sometimes we need to convince the surgeons based on the imaging that the patient needs surgical management. It doesn't happen very often, but occasionally we do see patients where there is such a discordance between the clinical findings and the imaging that decisions are made entirely on the basis of imaging. And pathologist, of course, is always supreme, because we said lipoma. There was, even in retrospect, when we look at the CT images, there was no reason to suspect a liposarcoma. The entire lead point was showing fatty attenuation. There were no solid areas, nothing which would make us suspect a liposarcoma. But then, of course, the pathologist found that it was a liposarcoma. Interception, as Joyner rightly pointed out, is essentially a pediatric population. We see it, because we are a tertiary care center, we see it fairly often in adults as well. In patients, in those patients, we almost always will find a lead point, which is the cause of the interception, and we look for that very carefully in imaging, and most often we do find a lead point in adult patients.
First of all, sarcomas in general are very rare tumor. Out of Sarcomas are very rare tumors. Out of all 100 tumors, sarcomas comprise of 1% of all the tumors that we treat. Again, this 1% of sarcoma, there are more than 70 types. So one can imagine the diversity of the sarcomas. And when we go in details of the data for each type, it is very scarce, and trials are also very compromise of diverse population, because it is not possible to have trial for one type of sarcoma. Another issue with the sarcoma is that the same histology can occur in head and neck, it can occur in extremities, it can occur in the abdomen and thorax. So it is a very wide diversity. But as far as this case is concerned, this is a very rare case. From our perspective, what we see here that this is a low grade sarcoma. So in sarcoma in general, we classify whether it is low grade or high grade. So in a low grade sarcoma, it chemotherapy doesn't work. In high grade, there is a benefit, but again, it has to be individualized decision for the case to case basis. And most important part for sarcoma, which as the senior resident has emphasized, we want it to be a R0 resection, that the tumor need to be removed. And if it is necessary, we have to sacrifice the organ as well, because if there is a residual tumor, then the patient, we cannot cure the patient, the intent becomes palliative there itself. So it was a very wise decision to go for a relook surgery and to completely remove that. Since it was a low grade tumor, chemotherapy would not benefit, and since the disease has been completely removed, we have planned for the subsequent follow-up. Had it been a high grade tumor, then in this well differentiated type of liposarcoma, which is one of the types of liposarcoma, it would have been an individualized decision. She is a 31-year-old patient. We would have probably given adjuvant chemotherapy had it been a high grade. But let us say a 70-year-old female had come with this same clinical situation, we would have omitted adjuvant therapy. So it's a case-to-case decision.
Thank you very much, Dr. Raju and Dr. Deepa. So basically, this patient, when she came to our OPD, she was practically all right, and she came with her mother, and it was a Friday, and next Saturdays we have our radio conference regular. When I saw her in OPD and when I looked at her CT, I requested Dr. Raju to review it there and then, and he was very kind enough to do that, and we had to really push her to get admitted, because based on the imaging findings, because she said, I'm fine now, why do you want to admit me? And she, young girl, parents are all have this concern of the marriage and surgery, cars and all that. Finally, we admitted her the same day, and then we got the ultrasound was done by Dr. Ankur. Very next day, we took her up for surgery, despite her clinical, features not being suggestive of something very acute at that point in time. The histopathology, of course, came as a big surprise to us. The biggest surprise was a second COVID, but it wasn't like 6-7 months had elapsed. It was within 2 months all this happened. Uh, First surgery, Dr. Hemang was there, and bowel walk was done. So our concern was also whether if missed in the first time, can miss it again. No, not be able to fix it. So we kept a possibility of enteroscope. Fortunately, as soon as then again we saw an interception, it was like God helped us to identify the lesion, and then a resection was. Now I would like to open for any comments and questions. Dr. C. Rajiv there. Yeah, please.
Liposarcomas tend to be more discrete, whereas lipomatosis tends to be a little more diffuse, have a larger area of involvement with a lot of it in the pelvis. How difficult or easy is it to differentiate a well differentiated liposarcoma from lipomatosis? How easy or difficult? A well differentiated liposarcoma versus lipomatosis.
So we vouch on the presentation. Basically, if it is a big lesion, if it is a deeper lesion, because morphologically there may not be very clear changes. I am talking about the soft tissue. So if it is a big lesion and deeply situated lesion, we always look for thick fibrous septae and look for if there is any occasional lipoblast and do MDM2 stain to identify atypical lipomatous tumor. But in this case, the problem was different because there were thick serosal nodules. We had to differentiate basically if this is just a serosal scar or serosal fibrous reaction or it is a liposarcoma. Fortunately, MDM2 worked in this case, S100 also worked in this case, and there are lipoblast and so many mitotic figures, so I was quite certain that this is a liposarcoma. And talking about the lipomatosis of the intestine is extremely rare, as has been highlighted, but lipomatosis has been most commonly reported in the ileocecal region. So at the terminal ileum part, so these lesions have been reported, most of them have been reported. We need to keep that in mind.
So even in the hindsight of knowing that there are multiple sites involvement, not a single discrete involvement, we would still be reasonably confident in saying it's a malignancy. At the end of the day, when we have looked at it, the fact that there have been 2 surgeries, there is an extensive involvement, probably over 30 to 40 centimeters of length of bowel, multiple discrete sites, you'd still be happy saying that it's a malignancy.
Yeah.
Very interesting case, managed very well. As pointed out, discordance between radiology and clinical and operative findings. I just have 2 or 3 things. One is that retrospectively, can you look back at the previous CT and see whether that lipoma which was causing intussusception could be found, or probably it got hidden by the intussusception which is occurring now. The second thing is that in the first surgery there was no lead point seen. So if there is a no lead point and you see an intussusception in an adult, you have to be worried as to whether you're missing another lesion. And lastly, like this is the era of minimal access surgery. Minimal access is the standard of care. But in minimal access, when we talk of the so-called walking over the bowel, you just see the outer aspect of the bowel, turn it here and this side. So if this lipoma at second surgery was felt clinically with hands, could it be that like in olden times, all patients used to do exploratory laparotomy? All patients, you open the abdomen, you first see the bowel from the duodenojejunal flexure to the cecum, and then you go and see the rectum. Then you examine the liver, then you examine the spleen, and then you start your surgery. That used to be the standard. So, but nowadays what you do is that since the imaging, as Raju said, helps us so much, sometimes, as Raju has rightly said, like sometimes they tell us, they call and tell us that this patient needs surgery, and very often we have benefited from it. So maybe the imaging has changed it, but I think an exploratory laparotomy probably is much better in such circumstances, especially when you felt that there is an intussusception, but there is no lead point. So I think that was one point which I felt should be highlighted.
Thank you, sir, for this comment. Since I was in the first surgery as well as second surgery, I should make few points more clear. The lipoma was size of 2 into 2 centimeter, and the duration between first and second surgery was 3 months. So it is sure that the lipoma was also there in the first surgery. We missed that. At the time of surgery, we reduced the since it was an emergency surgery, we took up in the night time. There was definite intersusception. So we reduced the intersusception. While reducing, we also noticed that there was already perforation. So we made a small fenestral incision and bring it out. Yes, as sir said, there must be some lead point. We also had the same query at the time of surgery. But the bowel was so thickened at that time, we decided that there may be some amount of submucosal fibrosis or some submucosal element which actually act as a lead point. And that's where we stopped. And although we searched whole length of the bowel, but that was with laparoscopy, we missed a lipoma. But at that time, the idea was that there was some amount of submucosal thickening, which was actually worked as a lead point. So we decided almost 30 centimeter of small bowel. But subsequently, whether those thickening was also features of lipomatosis or something else, we don't know. But yes, we looked for a lead point, which we missed in the first surgery.
second lipoma in retrospect on the first CT? No, we cannot. We've looked at the first CT. One drawback, of course, was that that CT was a private CT. We were looking at thick sections printed on film. And that's a huge drawback. When we look at films printed elsewhere, we are evaluating 5 mm, sometimes 10 mm sections of CT. When we look at those images on our console acquired by us, we look at 0.5 centimeter scans. So it was a small lipoma. It may have been missed at that time. It was obviously present earlier also, but we can't see it even in retrospect.
Thank you. For the benefit of undergraduate students and like first year postgraduates, like whenever there is a submucous fibrosis, intersusception usually does not occur. That's why they say that like malignancies, the adenocarcinomas which cause the fibrosis by infiltration, they rarely intersuscept. So it's for the benefit of the undergraduates and the postgraduates.
So Dr. Sinu has made very valid points. However, we have to keep in mind, one, the surgery was done at night. You had an obvious cause of a problem which was seen. And then when through a fan and steel incision, the bowel was taken out, even physical, by hand palpation was done for a significant length of the bowel. And if we look at the second surgery, the lipoma was found within 20 centimeters of the previous resected segment. So it's possibly that the heat of the moment you find a lesion, you find the problem, you want to get it out and kind of get on with rest. But a palpation, physical palpation was also done during the first surgery because bowel had been taken out through the fan and steel incision. So despite that, it probably got missed. That is one thing, because there was a question whether it's a recurrent thing. So in our view, it is probably not a recurrent. The time period is too short between the two. So if there are any other questions or comments, otherwise we'll call it a day. Thank you very much.